Hello everyone. Today we'll be discussing medulloblastomas. So the term medulloblastoma was initially described by Dr. Harvey Cushing. He's the father of the neurosurgery. He described this entity almost 100 years ago in 1925, and medulloblastoma was a tumor found in childhood and in the posterior fossa. Previously, medulloblastoma has been stratified by age at the time of diagnosis, the metastatic status, the extent of tumor removed, and presence or absence of large cell or anaplastic component on histopathology. After extensive study of the biological markers in the last 2 decades, the fifth edition of WHO has incorporated molecular diagnostics, that is molecular analysis, along with histopathology to generate an integrated diagnosis report. And with help of genetic predisposition, it is it helps in the clinical management of the individual patients, estimating prognosis and assessing biological behavior and guiding therapy. Therefore, treatment goal is aimed to improve the survival rate with minimal additional adverse effect and reduce long-term sequelae. As per fifth edition, the embryonal tumors are comprised of medulloblastomas, CNS WHO grade 4, and these account for 90% of all the embryonal tumors, and the other group of the other CNS embryonal tumors, and these are the entities. Medulloblastoma as a unitary disease. So medulloblastoma can be found at all ages, common in childhood, the median age being 9 years. It is the second most malignant childhood tumor after high-grade gliomas, and it accounts for 40% of all the posterior fossa tumors. Now, these are commonly located in the fourth ventricle or the cerebellar parenchyma, and they occur in setting of several inherited cancer syndromes and germline mutations. The diagnostic modalities are imaging. With the new advanced technology, uh, the molecular groups can be identified on imaging as well. We'll be seeing that in our slides. So next very important is histopathology and immunohistochemistry. So immunohistochemistry can be used to discriminate between the various molecular groups and subgroups of medulloblastoma. Now, the molecular study DNA methylation profiling is the standard method for determining the medulloblastoma group or the subgroups. There are other methods, and CSF cytology is used. Demonstration of tumor cells in the cytology is helpful in staging of medulloblastoma. So in 2016, the medulloblastomas were histologically defined and the molecularly defined groups and subgroups depending on the transcriptome and DNA methylation profiling. So the histologically defined groups are classic. Now in this, the tumor is composed of round to oval blue cells with increased cellularity. These are the primitive embryonal cells. You can see there's increased mitotic activity. Numerous apoptic bodies are noted. And in some cases, homocyte rosettes may be found. Or even there may be nodules of these tumor cells with pale islands. However, the reticulin uh, is not present in the classic type of medulloblastoma. They do not stain positive for reticulum. The second group is the desmoplastic or the nodular group, and you can see that these are multiple nodules of tumor cells with central pale island of cells which have neurocytic differentiation, and these are surrounded by cellular areas composed of primitive embryonal cells which are known to secrete collagen. So these are positive for reticulin stains. And the next is MBEN, that is medulloblastoma with extensive nodularity. Now, this is this medulloblastoma shows lobular expansion of the desmoplastic or the nodular variant and subtype, and you can see that there are pale islands in the center, and these lobules show lot of expansion, and they are of varying size and shapes. Next component is the large cell anaplastic. Now, large cell and anaplastic are two different components, but most of the times they are found in the same tumor. And you can see the cells. This is a very aggressive type, and the cells have high NC ratio, prominent nucleoli. There is nuclear wrapping, nuclear molding, and even nuclear pseudo-inclusions are present. This mitotically very active tumor, foci of necrosis may be present here. And the other variants are the myogenic variant and the melanotic variant. Now coming to molecular groups and subgroups, you can see this. There are four groups. The Wnt activated group, it accounts for 10%. It is quite a smaller group. And the SHH activated, it comprises of again two groups. In the group subgroup 3, that is P53 wild type and mutant, and the group 3 and 4, this is composed of a larger chunk of the medulloblastomas. This is a larger molecular subgroup. So coming to the Wnt activated medulloblastomas, the frequency is, it accounts for 10%. It's a childhood tumor. These are located in the dorsal brainstem. However, they may be found in the midline or in the CP angle or near the foramen of Leschka. And the classic predominant histomorphology here is a classic type. So this subgroup is very important because the children in this subgroup, they have excellent prognosis and they respond very well to the current therapy regimes. So it is a very important group. And the next group is the SHH activated. It is a P53 wild type and the TP53 mutant. Now these are located in the peripheral part, that is the cerebellar hemisphere, and the predominant histopathology in the P53 wild type is desmoplastic nodular, and in the TP53 mutant, it is the large cell anaplastic is more common. Coming to non-Wnt and non-SHH activated group 3 and group 4, these comprise of 8 subgroups, and the group 4 is the larger molecular group, and these are midline tumors. The histomorphology here is classic or large cell anaplastic. Coming to prognosis and prediction, so the patients with the children with Wnt activated medulloblastomas, they show excellent prognosis, especially when they are associated with APC germline mutation, that is adenomatous polyposis coli, and they show excellent response to the therapy. However, the same favorable outcome is not noted in adults. The SHH activated P53 wild type has intermediate prognosis between the two. The mutant has very poor outcome, especially in non-infants and adolescents. And now this group 3 and 4, these show poor prognosis when associated with MECAN amplification, isodiacentric 17q, high risk methylation profile, and when they present as a metastatic disease. Relatively favorable outcome is found in chromosomes whenever there's chromosome 7 and 17 gain, and loss of chromosome 8 and 11. Now we'll see metastasis is rare in the Wnt activated group, and it is more common in group 3 and 4, and the P53 mutant SHH activated may show present with leptomeningeal spread. Now coming to diagnostic molecular pathology, the Wnt activated group shows medulloblastoma shows CTNNB1 and monosomy 6 mutations. The two subgroups, the alpha, Wnt alpha is common in children and they demonstrate monosomy 6, whereas beta is found commonly in older children and young adults, and they are diploid for chromosome 6. So, coming to SHH activated TP53 wild type. Now, these will not show TP53 mutations. However, when they may show MECAN amplification, this has a therapeutic implication, and loss of chromosome 9, which is responsible for PTCH1 mutations, and these are associated with Gorlin syndrome or nevoid basal cell carcinoma syndrome. And now the SUFU germline mutations are common in infants. Coming to SH activated TP53 mutant, TP53 mutations can be demonstrated on immunohistochemistry or by NGS, next generation sequencing or Sanger sequencing. MECAN amplification should be seen, and there will be loss of chromosome 9. Coming to the group 3 and 4, uh, they will show isochromosome 17q. If we see the overall survival rate for Wnt activated, it is almost 95 to 100%, and it is almost 40%. That is the one with poor lesser survival rate is found in the SHH activated TP53 mutant group. So what I want to highlight here is, yeah, so let us go to medulloblastoma Wnt activated. So it is wingless INT beta catenin pathway. Now this is the CTNNB1 gene which encodes the beta catenin protein, and it plays critical role in the embryonic development. So these progenitor stem cells are located in the vermis, and during embryogenesis they are known to migrate to the peripheral part. So whenever there is mutation, that is whenever there is activation of beta catenin pathway, these tumor cells will get stuck up at that place. They will proliferate, and the nuclear beta catenin deposition will be found in the cells, which will give rise to tumorigenesis. Now these tumors, you can see, they are more commonly located in the CP angle. However, they may be found in the midline as well. So the Wnt activated medulloblastomas, these enhance brightly due to relatively porous blood-brain barrier compared to the other medulloblastomas. And at the time of surgery, they may be associated with intratumoral hemorrhage. Coming to the sonic hedgehog group, now the cerebellar granule neuron progenitor cells are present on the surface of the external granular layer, and these are known to proliferate and migrate to the internal granular layer. So whenever there is activation of this SHH pathway on the surface, it will stop the migration of these cells which keep on proliferating in the external granular layer, leading to the SHH medulloblastomas. So now how this name has been derived? It is derived, now this is the animal, the hedgehog, and there was a Japanese video game, Sonic Hedgehog, and you can see that these animated characters, they seem to have maldeveloped brain, cerebral hemispheres. So this is how it has derived the name. Coming to the subgroups, there are 4 subgroups: P53 wild type and mutant, and we have seen the TP53 mutants, they have poor prognosis. And these are the wild types are associated with nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome, associated with PTCH1 mutations. These are firm in consistency because their histopathology is desmoplastic or nodular. That reflects the intratumoral desmoplasia, and these are often circumscribed. And even on imaging, they may display grape-like appearance, bunch of grape-like appearance because of the nodular nature. So we have already discussed they have intermediate prognosis. So coming to this SHH activated P53 mutant group, now the predominant histopathology here is the LCA, large cell anaplastic type, and approximately 70% of cases indicating it is aggressive tumor. They are associated with several hereditary syndromes and TP53 germline mutations, that is Li-Fraumeni syndromes. And most of the times, CSF cytology is positive for these tumor cells. Now, how the diagnostic molecular pathology, we have to see for TP53 mutations that can be done by on IHC or sequencing, MECAN amplification, and indicates poor prognosis. Now, whenever these TP53 mutations are found in Wnt activated medulloblastoma, these do not indicate poor prognosis. So coming to medulloblastoma group 3 and 4, it is called as non-Wnt and non-SHH because activation of these pathways are not seen and very little information is available about this group. Now these arise exclusively in the midline and they are all, most of the times found in the inferior portion. They are associated with CREB double BP mutation, that is Rubinstein-Fabry syndrome. Uh, the group 3 and 4 medulloblastomas, they show foci of necrosis. Brainstem invasion is more common than other types of medulloblastomas. And the group 3 has contains macrocysts and are smaller than group 4. The morphology is classic and could be large cell anaplastic. So these are the factors associated with poor prognosis, and that is MECAN amplification, metastatic disease, and high-risk DNA methylation profile. So the fifth edition has laid down essential criteria according to which activation of either Wnt or SHH activated pathway or an appropriate DNA methylation. The desirable criteria for the subgroup has not been delineated. Medulloblastoma NOS, this terminology should be used if the tumor cannot be subclassified due to insufficient sampling, or those labs who do not do immunohistochemistry should call it medulloblastoma NOS. Now, I would request all the neurosurgeons to send maximum tissue to the lab so that the pathologist can carry out, give a histological as well as a molecular diagnosis, because sometimes when the tissue is small, proper histologically subtypes cannot be given. Immunohistochemistry is a surrogate for the molecular markers. It can be very easily done in the labs, and the Wnt activated will shows nuclear beta catenin positivity. Cytoplasmic positivity should not be considered, and these are YAP1 positive. The SHH tumors will show GAP1, YAP1 both positivity, and depending on the P53 wild type or mutant, we can see the expression. And in the group 3 and 4, all the three will be absent: beta catenin, GAP1, YAP1. If ETMR is ruled out by doing lineate, and INI1 expression, nuclear expression is retained in all medulloblastomas. So this is example of one integrated diagnostic report. The histopathology is classic. You can see the beta catenin nuclear positivity. GAP1 is negative, YAP1 is positive. So the integrated diagnosis is classic medulloblastoma, Wnt activated CNS WHO grade 4 with the molecular findings, that is CTNNB1 mutations. Similar it is for SHH and non-Wnt SHH. So medulloblastoma staging is done by MRI examination with contrast complemented by CSF cytology, which is done post-operatively 2 to 4 weeks. And there are M0 to M4 stages. So coming to the prognosis of the medulloblastoma patients depends on the extent of tumor resection, the histologic type, but you can see almost all subgroups, all groups, the histopathology overlaps. So what is important is getting done the molecular analysis, and according to which the radiation doses and the chemotherapy is planned, whether to add in the SHH inhibitors when it is a SHH mutant medulloblastoma. So there has been also a risk stratification proposed for non-infant age group, that is low risk, standard risk, high risk, and very high risk. So thank you very much. I have tried to simplify the topic. Hope you like it. Thank you so much.